So what we found was that there was a reduction in demand for healthcare and an increase in medical mistrust, particularly for older Black men who were kind of closer versus farther away from the centroid of this experiment, closer versus farther away from Macon County, Alabama. And we measured proximity in two ways. We measured proximity by, regular geographic distance, but we also used the Great Migration, so how linked people were to Alabama through migratory patterns of the Great Migration. And they both kind of gave us very similar results. So our estimates imply that life expectancy at age 45 for Black men fell by up to 1.5 years in response to the disclosure, which accounts for roughly 35% of the life expectancy gap between Black and white older men in 1980.
Not otherwise specified has always been one of my favorite phrases in medicine. Not just because it's a fancy way of saying we don't really understand the root cause of something, but also because it captures the human impulse to put tidy labels on things that remain largely unknown. In NOS, I talk with some of medicine's most innovative thinkers to probe some of these messy unknowns behind our healthcare system, its players, and the stories that shape their lives. NOS makes time for the types of in-depth conversations that may not leave us with easy answers, but that shed fresh light on medicine's toughest challenges, as well as the people envisioning its future. I'm Lisa Rosenbaum, and you're listening to Not Otherwise Specified from the New England Journal of Medicine. My guest today is Marcella Alsan. She is a professor of public policy at the Harvard Kennedy School, an infectious disease doctor, and an applied microeconomist studying health inequality. Marcella has published some of the most exceptional and creative work on health inequities, and I was thrilled, but not at all surprised, when she was recognized for her work with a MacArthur Genius Award in 2021. Marcella recently sat down with me to discuss her winding career path and her remarkable studies on medical mistrust, racial concordance between physicians and patients, and the effects of these factors on care-seeking behaviors and deeply entrenched health inequities. Marcella, I am so excited to get to talk to you today. Welcome to the show.
Thank you so much for having me. It's truly an honor.
So as you probably can imagine, it's not every day that I get to talk to an infectious disease doctor, applied microeconomist, MacArthur genius, all at the same time. So I have so many questions about your life story and your path, but you've published some of your seminal work in econ journals that some of our audience might not have seen. So why don't we start by talking about Tuskegee and medical mistrust. In 2018, you published a study called Tuskegee and the Health of Black Men, where you looked at the relationship between the disclosure of the Tuskegee experiment in 1972 and health utilization and outcomes among Black men in the 8 years that followed. And it's really a remarkable piece of scholarship because you take something that's so hard to study, which is mistrust, and you so elegantly suggest a causal relationship between mistrust and health utilization and outcomes in that period. So I would love to hear you talk about what the study showed, but I also want to know how you got the idea and how you came up with the methodology.
It's a fantastic summary, I think, of what the paper can and cannot do, with one small caveat, which is that the paper is not able to look at sort of long-term implications of the disclosure event. And one small, I think, important addition, which is the paper tries to understand how actions have consequences, how targeted exploitation of a particular group actually affects beliefs, and then moving on to that, demand for healthcare or behavior. And so the article addresses the specific disclosure of the Tuskegee syphilis experiment, which was egregious, and how it affects demand for preventative care, specifically among older Black men in the decade that followed. This question of how exploitation affects health over the long run and shapes beliefs is, I think, an important one that is still kind of on the table, but we were unable to capture. The first I heard of the Tuskegee syphilis experiment was as a college student in the late 1990s. I'm sitting in a class by Alan Brandt, who's a historian of medicine, and it really shook me to the core. I remember where I was sitting. I remember the lecture hall because at that point, I knew that I wanted to become a physician. And I was specifically interested in HIV/AIDS, so sexually transmitted infections more broadly. And here he was telling me that in the last 3 decades, there had been a study that was specifically targeting Black men. The official name of the study was the Tuskegee Study of Untreated Syphilis in the Negro Male. It lasted for 4 decades, which is an extraordinarily long time for any study. And it essentially was led by the United States Public Health Service, and they denied men access to treatment, and they lied to them. They said that they were studying, bad blood, quote unquote. And so that lecture, the series of lectures he gave on that study, really stayed with me, given, I think, that critical period of development that I was 18, 19 years old, and also just how it just seemed a complete anathema to what I thought doctors were supposed to do. But I didn't have the tools really to take it any farther than that. And it wasn't until I became a student in the PhD program at Harvard Economics that I both had access to some of the methodological tools that would make a causal analysis using observational data on this topic possible. And complementary to that methodological revolution, which has really occurred in econometrics over the last 1 to 2 decades, this is the causal inference revolution, as it's known. There has been an expanding view of, quote, what is economics, quote unquote, in the sense that there's a growing chorus of scholars who are interested in history and interested in intergenerational effects of events. So it was this combination of these two things coming together that made asking this question possible. And then I was able to find a really outstanding co-author in Marianne Wanamaker, who's at University of Tennessee, Knoxville, and is a card-carrying labor economist. But she was willing to kind of take the risk with me and do this project together.
Okay, so we all of a sudden got you went from being a medicine resident to a PhD in economics, which is so unusual. So I think before I hear more about the Tuskegee experiment and what you found and then how you put it together, why don't we talk about that leap? Because clearly you were interested since you were in college and you heard about this horrifying moment in 40 years of our history, but then you did go on and train in internal medicine, and I know that at some point you must have thought, okay, I'm going to go get a PhD in economics, but like, what happened?
Uh, I, you know, I don't plan ahead very. I don't. I do not. I just, day by day. And I think if I had thought about how many years everything would take, maybe I would, have chosen otherwise. At the time, I was honestly thinking very practically. I was thinking, what are the skills I need um, to do the work I want to do? And uh, I had gone into college thinking I wanted to become a physician. I wanted to work for Doctors Without Borders. That was um, life's my life's goal. But then, as a medical student, I had the opportunity to travel. And so I was in Quito, Ecuador at the public hospital. And I just realized that after all of this study of anatomy and physiology, and you're a medical student, you're so excited to draw blood and to start using all of this hard won knowledge. But in fact, what was happening was that it was all cash. Like there were no supplies in the emergency room. So if someone needed a blood draw, you had to ask them to go down the street to the pharmacia and buy, you know, they would need to buy the syringe, need to buy the needle, they would need to get any test tube or anything like that because there was just no supplies, no medications. Um, and it's just really dedicated staff. And that was the first part of my summer was working in that emergency room at Eugenio Espejo. And then the second part was doing an internship at the Institute for Health and Social Justice at Partners in Health. And at that point, I was reading this book, Dying for Growth, which was edited by Jim Kim and Joyce Millen, both medical anthropologists. And it kind of started to rationalize what I was seeing on the ground. It talked about macroeconomic policy, it talked about structural adjustment programs, international financial institutions, the gutting of social services in health and education in order to make debt payments. And I just thought, wow, this is this entire language that I don't have. And I feel like I need because all of these tools in clinical medicine are kind of being wasted in the sense that because I don't have again, my very practical, pragmatic thinking, I can't cure poverty. So what's the doctorate for that? So it turns out that a PhD in economics is not a magic bullet for poverty, but I think it did increase the depth of understanding that I have for these issues. It did give me a new set of tools to kind of address, as we were discussing the Tuskegee study, you would never want to randomize medical mistrust, but unfortunately, you can leverage the fact that there are plenty of historical incidents. Um, and so it sort of broadened the toolkit that I have to address some of the questions that I think are important.
So, okay, so then let's go back. So you go to Harvard after you finished your internal medicine residency. Did you know then you wanted to do microeconomics?
Well, I have to say that I had a lot of mentorship along the way, and I had people who saw in me more than I saw in myself. So I started off with a master's of public health, and David Bloom said, you seem like you're kind of taking to this economics uh, uh, field. Why don't you think about a PhD? So, so I took the GREs as a fourth year med student. And then when I applied, again, this was a fairly new innovation, the Howard Hyatt
Global
Global
health.
Health Equity residency, right? When I applied, I kind of mentioned to Joel Katz, the program director at the time, that I was interested in this. And so, you know, Dr. Katz did what Dr. Katz does, which was write to everyone. I saved the email where he's writing to Howard, he's writing to Jim Kim, he's writing to Paul Farmer, he's writing to David Cutler, and he's coordinating. He's saying, the goal would be to get her out of this training before she's Medicare eligible. But she has this vision, and let's see if we can make it a reality. So I applied to the PhD program as an intern, and then I deferred, and Joel made it, Dr. Katz made it so that I could short track into the PhD in economics and the infectious disease fellowship.
So you're in this econ program, and I kind of want to know what that was like for you after you had been in medical school and internal medicine. We hear a lot now about how it's hard on women to be in economic PhD programs, and I'm sure it was hard to be learning this completely different skill set. So what was that experience like for you?
Well, I can't separately identify the effect of being, coming out of a second year residency and being a new mom. So I had a 6-week-old when I started
Oh my goodness.
the
Wow.
PhD program.
Wow.
Um, and so that was different for a lot of the administration in the PhD program. But I have to say that people went out of their way to make it possible for me to continue. I mean, unlike the sort of modal PhD student, I had a pretty good outside option.
Right.
If this didn't work out.
Yeah.
And clinical medicine is so fast paced and so team oriented and so instant gratification when you can clinch that diagnosis and see the patient's fever curve turn around. And here you are, studying things that are, especially the first year coursework is, it's, heavily theory based and it doesn't seem super practical, at least, again, compared to where I was coming from. But I had a lot of support along the way. I like to tell the story of another really terrific advisor, David Cutler, who would just meet with me regularly. And I would say, David, I think I might need to quit this now. And he would say, give it 2 more weeks. Every 2 weeks, this was our conversation. I think it worked itself out in the end, and it's been exciting, especially as you move forward in the program. Once you get past, your general exams in macroeconomics and microeconomics, you move on to econometrics. Then you get to do field coursework in public economics, in development economics, and labor economics, and that's where it starts to really feel like, almost like your third and fourth year of medical school. You really start practicing your craft. You turn the corner from a consumer of information to a producer of research, and that's where it becomes much more gratifying. I stopped asking every other week about quitting at that point.
Okay, so I know you did a bunch of work in between, when you were doing your dissertation and when you published your data on Tuskegee, but I do want to hear what you found in that study and have you describe the methods because they really are so elegant.
Well, going back to the official title of the study itself, the PHS study is the Tuskegee study of untreated syphilis in the Negro male. So that tells one 3 things off the bat. It's taking place in Tuskegee, Alabama. There are individuals who have been identified as suffering from syphilis who will not be treated, and it's specifically targeting Black men. And then you combine that with the fact that this disclosure event was, this incredible whistleblower, Peter Buxton, in 1972. Um, that gives you a date. So you have a, socio-demographic, you know exactly who they're targeting, Black men, where they're doing it, Tuskegee, Alabama, and when. And so we combine all of those features, and it was older Black men that we were interested in at the time of the disclosure event because many of those study subjects would have been older by that time if they had survived. So we combined all of that in a difference in difference in difference in differences approach. Yes, that is the appropriate title, but essentially leveraging the fact that it affected this particular group so we can compare, you know, Black men to other demographic groups, older Black men to other older demographic groups, be it white men, white women, Black women, etc., nearer versus farther from the study site in the period before versus after the disclosure event. And we can absorb all, because we have so many differences kind of baked in, we can absorb a lot of other potential threats that you might think of when you're trying to use observational data to draw a causal inference. So we can take into account that there might be other changes happening in those areas to Black individuals overall. And in fact, most of those other changes that we're thinking of in the early 1970s would have actually been pushing towards convergence. Things like the desegregation of hospitals because of the Medicare and Medicaid introduction, or just the improved knowledge of how to treat certain conditions and things like that. Um, so, so what we found was that there was a reduction in demand for healthcare and an increase in medical mistrust, particularly for older Black men who were kind of closer versus farther away from the centroid of this experiment, closer versus farther away from Macon County, Alabama. And we measured proximity in two ways. We measured proximity by just, regular geographic distance, but we also used the Great Migration, so how linked people were to Alabama through migratory patterns of the Great Migration. And they both kind of gave us very similar results. So our estimates imply that life expectancy at age 45 for Black men fell by up to 1.5 years in response to the disclosure, which accounts for roughly 35% of the life expectancy gap between Black and white older men in 1980.
And what was the response to your paper like?
I think this was the closest that I have been to feeling like a physician feels when you make that diagnosis and you feel the gratitude from from a patient or a patient's family because maybe they haven't felt heard. Um, so we, Marianne and I, were delighted by the fact that first, when we were presenting the study, so this would happen in economics, you typically have these very lengthy papers, and you put them out as working papers, and you kind of go around to different seminars, and not so much in economic seminars because we have a diversity problem in economics that, again, you mentioned before that we're working on. But I would also present in sort of population health seminars. So that would bring together many different disciplines, sometimes even members of the community. And so we started to get these reactions. I remember one woman came up to me, and she was a pediatrician herself, but she grew up in Ohio. She was Black, and she said that she remembers that her parents would drive them hours to go to a physician that was Black when she was little, and she remembers it happened after this event, and that they felt like they couldn't trust doctors to see their kids after this event, and then So we would get these anecdotes, and then Van Newkirk, writing for The Atlantic, was interviewing us, and he had his own personal story from his grandparents and his parents. Um, and he didn't only just write about our study, he actually went on social media and he collected all of these anecdotes um, from people that had memories of this, had experienced this. Um, and so we, I think there were two feelings. One is just absolute um, gratitude towards all of those individuals that had shared their stories and provided some affirmation for what we were doing. Because even though I mentioned, there was these methodological revolution and then this sort of new openness to looking at history and how that might affect development more broadly, it was still a little bit out there. But second of all, I think just as you are as a clinician, you're always hoping that you got it right. You're always looking for the clinical parameters to suggest that indeed, this is the right path forward. I feel that way with my research. I still feel like this is the best we can do right now. And as the field progresses, we might have new methods. Might get better data. We might update the conclusions. So this was just like an incredible gift to see in real time that it resonated with people, the exact people that we wanted it to resonate with. Yeah, there was pushback from other corners of um, talking heads and things like that, but that is all just
Noise.
noise.
Yeah.
Absolutely. Once and honestly, that was the closest experience I've had to sort of being a doctor and getting energy from the patient side. Like, thank you for hearing me. Thank you for listening. Um, Thank you for taking this on and asking these questions and looking for uh, looking for answers.
Wow, that's so moving to hear about that. I mean, and it's just it's an exceptional study and analysis. Let's fast forward because I know that when you discovered the impact of medical mistrust, something in your head went, what can I possibly do about mistrust?
That's right.
And so all of a sudden you're conducting an RCT unlike any I've ever seen, where you literally built your own clinic and you studied whether race concordance affects uptake of preventive health services among Black men in Oakland. And it's just another exceptional study, which I imagine was harder to operationalize. As sophisticated as the econometrics are, conducting an RCT where you have to build your own clinic and do something that nobody's ever done was probably harder. So I would love to hear first how you got the idea, because you could have studied any intervention to address mistrust and you chose race concordance. So I want to hear about that. And then I want to hear what it was like.
Well, you're right that there's a whole set of things that we need to do as a society to reduce inequities in healthcare, racial inequity in healthcare, income inequality and inequities in healthcare, and in health outcomes, I should say. So the two things that led me to study um, racial diversity amongst the physician workforce was one, what could I actually experimentally manipulate? Like, what could I actually, what's in my feasible set? I can't, I can't randomize. Though some people have, done this, but I didn't have the connections to sort of randomize the offer of health insurance or things of that nature, or some of the other important social determinants. Uh, so it was, what's in my feasible set, and then two, what are the leading medical institutions, our esteemed institutions, the National Academy of Medicine, the AMA, the AAMC, what are they saying in terms of what could move the needle on improving outcomes for Black Americans? And they all have these statements, mission statements on, policy positions that we should have a workforce that more nearly represents the population that it's trying to serve. And so with that in mind, and this was totally, could never have done this without the relationships that I forged, particularly with Dr. Owen Garrick, who is a physician by training as well, who at the time ran his own nonprofit called Bridge Clinical, which was seeking to improve the representation in clinical trials, and was from Oakland. So we, alongside a graduate student, Grant Graziani, started these conversations about, okay, well, what clinic can we partner with to do this work? And I should say that when I initially brought this to sort of other economists, I think a natural response was, well, why don't you just use observational data to draw causal inference, because that's a lot easier. We can get some quasi-experimental variation from random matches in the emergency room or something like that. But I really wanted to study preventative care, and I really wanted to look at people that were not, there's something about coming to the emergency room. You're obviously in extremis. That's a different frame of reference in terms of your mental model and decision making than when you're, when you're trying to seek out preventative care. So, that wasn't the mental model that I wanted to get at. A lot of, from a health economist standpoint, I think the party line would be that preventable emergency room visits are actually something we want to avoid from a quality standpoint and a cost standpoint. And then again, I think we really need to think about, what's the policy relevant parameter that we're trying to estimate. And I think most clinicians would agree that if you can prevent or capture a disease at an earlier stage, the opportunities for changing the trajectory of the illness are just so much greater. So we kind of set aside the idea of using observational data and some of the causal inference revolutionary stuff, and thought, okay, let's do a good old-fashioned RCT, something feasible, something policy important, relevant, important. So naturally, let's go just partner with a clinic in the Bay Area. And then the problem, Lisa, was that we couldn't find one clinic that had an African American male physician. I'm not kidding. It wasn't because we thought, let's start a pop-up clinic. It was literally did not exist. And I think that speaks to how profound the problems of, having Black men represented. I mean, again, diversity more broadly too, but particularly Black men, the numbers have just been low and stagnant since the 1970s. And so it was really out of necessity that we partnered with a allergist who just happened to not have clinic on Saturdays and allowed us to work in that space. We brought together physicians, and we were able to hire over a long period of time enough clinicians, Black male physicians, non-Black, mostly white or East Asian male physicians. And then it was also really important that we brought in people that weren't routinely seeking care, which is another problem with administrative data. If you're in the system, if you're looking for people in the record whose information is not out of date, by the way, because of the churn and all, separate discussion, but whose contact information is actually up to date and who are regularly in the system, that is not, again, the policy relevant estimate that I was looking for. I'm looking for men coming from the community who would have these really high returns for preventative care. And so that was Dr. Garrick's brilliance, was like, let's use barbershops to recruit, because men are generally, this is a trusted space. People that hang out there, people from all walks of life. You follow your barber, you don't go to a specific shop. So if your barber changes shops, you go to that shop. So you can get people crossing zip codes left and right. So what is this estimate? This estimate is conditional on having meaningful access to a quality healthcare provider, because our clinic was open on Saturdays and Uber donated ride sharing.
Oh, wow.
So we had transportation, we were open, we had space. Conditional on that, this is the estimate that we get from randomizing the men who came to our clinic to either a Black versus non-Black provider.
So I know you 1,300 men or so were screened, right? And then more than 600 showed up. And then you randomized them, but then there were 2 phases of the study, right? And so
Precisely.
what did you do in the first phase, and why did it matter?
Great question. So the way that the clinic worked is they came into the patient room and they were received a tablet in which this was the first stage. We called it the preclinical encounter stage. They had a photograph of the doctor that they were going to see, and then they had an opportunity to select which preventative services, if any, that they were interested in receiving that day. Then in the second stage, the encounter stage, they actually met that same doctor in person, and then they could re-optimize. They could choose different services. They could say that they don't want specific services. The services that we offered, by the way, were blood pressure, BMI, so height and weight. Those are kind of the more non-invasive things. And then we had cholesterol and A1C, diabetes, which were took a finger prick of blood, and we had these devices that you could on the spot give you readings of your cholesterol and A1C. And then we also had flu vaccination donated by Alameda County. So they could decide, again, they could say, in fact, I don't want those things, or I want those things. And the doctors were just told, the doctors, by the way, were blinded to the actual rationale for the study until afterwards. We told, all of them knew that the goal of the study was to provide preventative care to Black men who might otherwise not have a resource. So you have to think about the selection of the doctors who were going into this. This is probably like, the best of the best in terms of what you're going to see in discrimination wise. So their job was just to go in and try and talk to individuals about the importance of preventative screening, period. And why we had these 2 stages was because we were trying to disentangle 2 different hypotheses. So you can imagine that if our patients after the first stage just made a snap judgment based on the photo and said, look, I'm willing to take up more preventatives under this type of doctor versus that type of doctor, that might suggest that there's some sort of taste-based preference for a particular type of physician. And we weren't sure which way it would go. That's the equipoise in which you're supposed to conduct clinical trials, is it could go that people kind of prefer doctors who, quote unquote, looked like them, just all else equal, just by seeing a photo. Or it could be that, internalized racism and such could go the opposite way. You really didn't know, but it would be a snap sort of judgment based on a photo and minimal information that we gave on qualifications that was symmetric across all doctors. And it would reveal a particular taste. On the other hand, if it wasn't until the second stage when they actually got to meet the physician in person and talk about the preventives that were being offered. Maybe it would actually really matter, that rapport, that communication, that trust. And indeed, what we found is absolutely no difference in the demand for preventatives in the first stage. There's no sort of snap judgments being made. There's no particular taste or aversion that we detect. In fact, all of the difference that we see, and it's a pretty pronounced difference that we see in the demand for preventative care, comes after that second stage when the doctors and the patients actually have a chance to interact. And that suggested to us that it's more about something about the reverence of the clinical encounter and the rapport that you need to establish between a doctor and a patient in order to, produce health.
So I'll never forget when I interviewed you about this maybe 2 years ago. I asked you why you didn't submit the data to the New England Journal because it's an RCT and it shows really a remarkable effect and increased uptake of preventive services among Black men when they are randomly assigned to Black doctors. And you said, well, there's no mechanism of action. And I said, well, what do you mean? And you described to me, and I think it's what you're beginning to get at right now, but some of the interactions and what you overheard in the hallways and some of what was going on in the notes. So can you talk a little bit about that?
Yeah, absolutely. And talk about some of the, the broader differences between, economics as a science and I think the biomedical sciences um, as well. But yeah, so we thought that there were several possibilities that could explain these results. So the second stage clearly put the focus on the encounter itself. But what was it about the encounter? Were the non-Black doctors, were they discriminating against the men? Like I told you that the selection is such that it didn't seem, a priori that would be high on the list, but it certainly seems possible. Maybe I selected just the cream of the crop Black doctors. Was there some sort of quality differential or effort differential? How do you measure effort? It's difficult, but we looked at time spent in the encounter and conditional on choosing just more stuff that takes more time, like adjusting for the average time those tests take to run, there was actually no difference in the amount of time spent. Okay, physician resumes, no differences there. We did a little bit of a sort of screening test on medical knowledge, no differences there either. I mean, we weren't asking them to do extremely difficult, challenging tasks where quality differentials you would think would make a huge difference anyway. So set that one aside. What about bias, discrimination by the non-Black physicians? So we can actually look at that. So maybe for those who actually got screened, for example, for an A1C, we would see higher values for those patients who were assigned to non-Black physicians because the physicians were implicitly using a different threshold. So you didn't just have to have, polyuria. You also had to have, some other indicator of diabetes, that polydipsia or something like that, that would kind of change the threshold, or you had to have a family history that was like something else that would make the threshold that the doctor was using on average higher for those patients that were paired to a non-Black physician versus a Black physician, so that on average the clinical parameters were more averse. But we don't see anything like that. More basically, when we look at the patient comments on the doctors, they love all the doctors. They're extremely positive. They're rating them all, on average 4.9 on a 5-point scale. Like this would be Press Ganey scores that we'd be really excited to get. So it just didn't look like that was any of those other sort of mechanisms could explain the result. Communication wise, when we looked at the notes had more details about the patients in them. And in fact, what we were seeing popping up in those patients that were assigned to non-Black physicians, we were seeing them say things like, you know, not now, just like putting things off a lot or talking about a PCP. Patient will get at PCP, even though we knew from the barbershop surveys that the vast majority of these men did not have a PCP. And so I think it was a sense of just either miscommunication or, I just want to tell this person something so that they'll stop bothering me, or I can tell this person doesn't want me to bother them, so I'm just going to write. We can't get farther than that. But whereas in the notes from the Black physicians, we see all of this detail about their life, in the text analysis. They were more efficient at extracting information, useful information. And whether that's, communication is, we're two ways. And so in this race concordant dyad, there was more efficient extraction of useful information that could be leveraged to persuade and lead to a higher take-up of preventative care. But there are shortcomings to any study. This one is obviously no exception. So, what are the drawbacks? 14 physicians. How representative are the patients? This is, a local average treatment effect in Oakland. Does it extrapolate to this situation or that situation? I think at this point there have been sort of those quasi-experimental studies looking at matches of women when they're coming in to give birth that seem to suggest a concordance effect there. There's been other sort of corroborating evidence along the lines, but I think it shows, whether or not the magnitude is totally accurate or applies in all different settings. There's reasons to think that it could be a lower bound, given that I didn't find evidence of discrimination, which we know exists. So, imagine the generic interactions that you might see. But it could be an upper bound because we sorted all these other social determinants. We just wanted to not have those interfere in some way. And this is the difference between obviously being a social scientist and being sort of a bench, wet lab scientist, where you can hopefully control the environment, get the mechanism at the molecular level, and make sure that it will reproduce with much fidelity time and time again. And this actually goes back to why, Van Newkirk was so helpful for so many reasons, because I can look at those two different spheres that those, the burden of evidence that you need to really make it past the FDA and, in general, and the level of certainty you need for that. And in social sciences, and I have to say that I feel a little bit hesitant sometimes to make really strong pronouncements, because I know that it's just the exercise in and of itself is going to be doesn't have the molecular basis in the back of it. So when it resonates with people, and when you get that sort of reaction, it really I think helps to affirm that you are indeed on the right track.
Right. We know we have a massive problem of underrepresentation. So you didn't have to show that. And what you established is that underrepresentation is causing worse health, it seems to me. And, I don't think you need to pass the FDA bar to have, plausibly establish that relationship. And I hope that was the response to the trial. We need a different standard for establishing, I don't know what the right word is, social science meets medicine, but it's not a drug trial.
Yeah. No, it, so, and there, I mean, there are efforts coming out of Berkeley and to, improve transparency in pre-analysis plans and replication, replicability. But yeah, it's going to be a different exercise. It's going to be, I guess, is what I'm saying. It has to be a mosaic of evidence, and obviously with humility, which is what you bring to clinical medicine too. You look at both the RCT, you look at the observational analysis, you look at the qualitative studies, the qualitative remarks from people who are at the front lines who've had these experiences, and you kind of put that all together. I guess what I what I am thrilled about is that I do think sometimes the RCT is the missing piece, in that mosaic. And I was so thrilled with the team that we put together with the funding from the Poverty Action Lab at MIT, which really took a chance on us, that we were able to execute the study with fidelity and show the results, because it's also just extremely easy on the mind to say, we randomized, here's the mean for this group, here's the mean for that group. No difference and difference and difference and difference. No, no, we need several pages to describe the assumptions and not whatnot. So it is just it's a extremely powerful way to kind of communicate scientific findings. And I think it alongside these other pieces can really help with the narrative.
I know, and I think it did. And one thing I'm curious about is whether you feel like your leap into this space using a randomized controlled trial to study an intervention is inspiring other RCTs, or that level of evidence, which we need, because it's what people respond to.
I hope it does, but it was made possible by this causal inference revolution, and Esther Duflo, Abhijit Banerjee, Michael Kramer received the Nobel in economics recently for their work bringing randomized trials to development economics. I mean, this is building off of many, many others, and then the Poverty Action Lab providing funding for this. But I think, obviously, with all of the, needing equipoise, needing to make sure that you don't already know the answer to the question, and that things are being done in the most appropriate way possible that will actually be of societal benefit. I think there's no doubt that translating to policymakers the findings from an RCT is just infinitely easier than discussing,
A
any
quadruple
other
difference.
a quadruple difference. Right. Exactly, Lisa. You've
Yeah.
got it. So I just want to acknowledge, just because I haven't, not only the funding and Dr. Garrick, but also the students. We had a lot of students helping us too, and they were fantastic. And I'm one of the things that, it's scary to do an RCT on something that is potentially so policy relevant and important. But I thought to myself, okay, at least we're going to get a lot of people screened, hopefully vaccinated. And then the students working for us, a lot of them got to say that they, were RAs at Stanford. And they weren't Stanford students. There were a few Stanford students, but a lot of them were from Oakland, from the community colleges around Oakland and things like that. And that was just really terrific. So that is another very cool thing about doing field experiments, is kind of bringing along a whole generation of researchers and other scholars.
Why don't we do this? Tell me what is hard for you. I think this is important also for trainees to hear, or PhD students to hear, because here you are, and if they Google you, they're like Marcella Alsan, MacArthur genius, has published this seminal work, in health inequities, but obviously like life goes in many different directions before you get to that point. So what do you feel like have been your biggest challenges?
Well, for the trainees, I just have to say their ability to absorb information and to already have such intuition about theory and evidence and data. I mean, that's really remarkable. I mean, I'm talking about the masters in public policy and some of the undergrads, but I mean, it's really exciting to see how advanced they are in their thinking at a stage where I was so much just really confused and just trying to find my way. I think the students are just have absorbed a lot more information at this point and are really savvy, um, which is exciting. And I still struggle with being a little tentative sometimes, being a little bit intimidated sometimes, um, and uh, and I think that doesn't do anyone any good. Uh, so um, I just try and tell students to have ratatouille approach to life. Anybody can be an economist. Anybody can be someone that works in medical sciences. Everyone has something to offer. We all have this just brief period of time to to find what we love. This is the three questions. What do we love? What are we good at, and what can make the world a better place? So just go for it. And then all that self-doubt, that's just inefficient. It doesn't just try and cut it out.
I love you are such an economist. I mean, I'm gonna say that to myself. I mean, I feel intimidated all the time. And like the way I don't think of it as inefficient because I don't think like you think, but I think, well, at least I'm human, and then I can help other people feel more human when they feel the same way, because it's very hard to just like remove it.
It's very hard. I mean, if there was a pill for that, can you let me?
High bar for FDA approval, right? No, I know it's. I think it's good for people to hear that even somebody like you still feels that way, and I don't know how much society needs to change to make people like you not feel that way, or if it's just something that we do that I don't know.
I think a lot of it is internal. I mean, but of course, we're absorbing a lot of what of 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 societal expectations and whatnot. But I think if helping people is the objective, then you can kind of get yourself to the point where you're taking these risks, where you're finding the funding, finding the mentorship, finding the data, putting it together, running for office, whatever it might be. If you can find the confidence to do those things, if you kind of remember, okay, this is what I'm doing it for.
I think that is an awesome place to end.
Okay. Well, thank you so much for having me.
Oh,
I'm
you
so
were
honored.
amazing. You are just so amazing. I'm so happy to have gotten to talk to you. My guest is Marcella Alsan, a humble MacArthur genius, economist, physician, and professor of public policy at the Harvard Kennedy School. Marcella's work has helped illuminate some of the key causes and mechanisms of racial inequities in U.S. health and medicine, and it provides direction for physicians, health systems, and policymakers who need to work toward solutions.